Good morning, everyone. Madam President, honored guests, ladies and gentlemen. It gives me great pleasure to introduce our guest of honor, Peter John Gill, winner of the IODE War Memorial Queen Elizabeth II Diamond Jubilee Scholarship. Peter was born in Edmonton, Alberta, where he attended the University of Alberta and where he received his Bachelor of Medical Science, and where he is enrolled as a medical student in the Faculty of Medicine and Dentistry. Mr. Gill is presently on leave of absence after finishing 3 years to complete a Doctor of Philosophy degree as a Rhodes Scholar at Oxford University in the United Kingdom. Peter's strong vision, commitment, and passion is to improve health care in Canada, especially in children. Peter finds time to mentor new PhD students, teach undergraduates and medical students, and to represent over 7,800 Canadian medical students in the Canadian Medical Association. He is still involved in PED cases, a medical education project he co-founded to develop educational resources for future medical students. Ladies and gentlemen, it is with great pride that I ask you to join me in welcoming Peter John Gill, winner of our highest award ever, the Queen Elizabeth II Diamond Jubilee Scholarship. I'm now going to present Peter with a certificate, and then I'm going to ask our national president to give him this $25,000 check.
Thank you very much.
And I'll give this to Madam President, and there's from my hand to yours.
My hand to yours, Peter.
Thank you this is an incredible honor to be here today. I'm going to be speaking later, so I won't take up too much time because you'll be forced to hear me speak in a couple hours. But this is just such a privilege and honor to be here. Just the chance to actually be a part of this organization. And my mother-in-law volunteers for IODE in Edmonton for many years. And it was her idea to put me forward for this award, and she seemed to encourage me. Yeah, so I have to. The women in my life are very important to me.
She's a good mother-in-law.
Yeah, she's a great mother-in-law. But honestly, IODE does fantastic work in Canada, and has done for many years, and to just have this honor to be acknowledged, to be a part of the organization as an honorary male is great. So what I want to talk to you about is PEDS cases, and what this is it's an initiative that I founded with a colleague of mine, a medical student, in my second year med school. It's really just a tool to help medical students achieve their learning objectives around pediatrics. So today I want to just go over just the journey of how we started that and where we are now. And so I thought I'd start my first slide with a plane for two reasons. Firstly, because I just got off a plane yesterday, and I'll be flying back tomorrow. And secondly, because I think it's really been a journey, and in any initiative that you start in the beginning, much as IODE was started in the beginning, it's a journey that has turbulence, and it's challenging, and you work through it. And so since I was a kid, I had a great pediatrician, Dr. Martin, and every time I went and to go see him, it was a lot of fun. I really enjoyed going to the physician. And so I got really involved in doing a lot of coaching when I was in high school, did a lot of work with children with disabilities, running summer camps and programs. And this is a photo of someone who I work with named Justin Wack. And he's someone that was born with a syndrome called Norrie syndrome, which he was born blind, and he progressively has lost his hearing. It's a really rare, there's only about 24 kids in Canada with this condition. And this is him singing the national anthem at Commonwealth Stadium 2 years ago. And in the back you can see Sidney Crosby and Steve Eiserman and other Olympians. And he's someone that I got involved with because when I was running these programs with children with disabilities, I really got along well with him, and his parents asked me to help do respite work with him, which is just helping the family as you can. And he's someone that, despite his disabilities, he's gone on to compete in the Paralympics. He plays soccer, does judo, and he sings. So these are sort of my inspirations of what I take with me going forward. So, well, what is PEDS cases? And I think to describe anything, it's important to go back and describe the context of which it was started in, and what was the circumstances of which we created this initiative. And so back in 2007, when I started medical school, the way that med school was taught was very traditional. We had 30 to 40 hours of lecture a week. We'd go sit down in a lecture hall, and we would just get taught. We would memorize the material and then regurgitate on exams. And that was a very traditional model of didactic lectures, the way it used to be. In pediatrics, the way we were taught child health was very much distributed throughout our first 2 years with different lectures, and then we learned most of the material in third year when we did a 6-week pediatric rotation. That was where most of our core learning. But you can imagine, and many of you have children or grandchildren, that kids get sick with different things different times of the year. So in summer, it's often allergies or asthma flares up. But in the winter, it's chest infections and croup. And so if you did pediatrics in the summer or the winter, you got a very different perspective of what you experienced. And what we want our future doctors to be able to deal with all these core conditions. So at the time, there was this program that was developed by an American university, which our university was paying $10,000 a year for, which helped students do these cases that if they didn't see a child with a certain condition, they could do a case online. But it was an American program that had all American units, and it wasn't very good. So we had the idea to come up with something that we developed that was for Canadians, that was for medical students, that was driven by students based on what we felt that we needed to learn on. And so this is where we developed PEDS cases, which was basically it's a student-driven initiative that helps medical students achieve their core learning objectives using different modalities of learning. It can be questions, cases, audio podcasts, different ways just to help students get to the end goal of being a competent individual that knows these core objectives. So really about targeting things that we felt were deficient, but we could fix it and do it ourselves and put it in our own hands. And another thing that was important was doing multiple cases. So most of our exams in medical school are multiple choice exams. But when a child comes into your doctor's office sick, it's not a multiple choice question what you do, right? And it's more complicated than that. You take a history, and then based on that, you'll do an exam, then maybe order some tests. So it's an iterative, ongoing, dynamic process. Yet we get tested by a single question. So to make this more representative of how you actually see patients in real life, wanted to create these cases that had multiple steps to them. And usually a question, there's never just one right answer. There's always usually multiple choices. If you're going to order blood work, you don't order, when you go to doctors, it's not like they have one test to order and that's it, right? There's usually a whole sheet of scripts to order, and you can pick different types. But the way that we ask questions is a single right answer. So we wanted to create cases that had multiple right answers, so there was 3 or 4 were right out of 12. Which is more representative and reflective of how you would actually function in the hospital or in the clinic. And then one thing that we did, I think this has been one of the biggest successes, is what we created podcasts. And at the time, these weren't really used for lectures, for academic content, but we felt that, as a simple way, students could then refresh themselves on the important material to listen to a nice 50-minute short podcast to summarize how do you assess a child with a fever. What are the key points that are a really simple, concise way that students could use anytime they want. They could download it for free and before the exam listen to it, or if they're in the clinic and they're not sure, at lunchtime listen to it. So a really simple way, and again being a free open source for anyone around the world to download. So on iTunes you can go, not that I expect you to download any of these podcasts, but you can go and download them for any of the core material. And this has been something that I think has really been well received. What are our numbers like? We have over 20 podcasts, which are 10 to 15 minutes long, and most of them are not done by me, thankfully, because I don't have a very enjoyable voice to listen to. And then we have about 50 cases, multi-step clinical cases, about 200 questions, and different types of quizzes and videos. And so to date, we have had over 25,000 unique visitors around the world. as well as over 120,000 downloads online. With Google, you can collect really good data and statistics. So you can see where everyone around the world is, where they're coming from when they go on our website. So you can see, and out of our top 10 countries that visit Pete's Cases, we see that 3 of them include Malaysia and India and Pakistan. So we see that it's getting in settings that are developing countries, that are low income, that couldn't really afford paying this $10,000 per year subscription to a resource that they wouldn't otherwise have. And it's important to get education to everywhere that it needs to be, and education should be free. It shouldn't be behind paywalls of access. And this has pretty much been a model that's driven us ever since we've started, that it should be open for everyone to use around the world. And with our podcast as well, they've got a lot of usage, and that looks like a bit of an erratic graph just because we have a lot of people that subscribe to the podcast, and so whenever there's a new one, they automatically get it downloaded to them. So when we can see, what's the most popular podcast, where the downloads are coming from, and again, most of the downloads are from US and Canada and Australia, but a lot from India and Pakistan and some parts of Sub-Saharan Africa, which is really good for us to see that it's getting into areas that I think are in need of education resources for free, and then to modify and adapt as we see that where the demand is going. And it started with a fellow in my med school class named Dan Kozan, who was from Saskatchewan, who started med school, and he was just a creative genius. He would doodle in class, and that would come out at the end, that artwork. And it was just spectacular. He's now doing plastic surgery, so I think he's found his home. And so he created this amazing database, which now has over 7,000 questions. And again, it's free, open source. It's just for everyone to use around the world, and for students to fill those gaps and to say, well, we have a deficiency here. Well, let's fill it ourselves. We don't need to wait for the educators, the system, to do it for us. Let's take it into our own hands. So when he created this, we had this idea that, well, we felt that pediatrics was not taught the best, so why don't we create something similar? We can do it on our own. So we had this idea, well, why don't we create, Pete's Cases, essentially this comprehensive student-driven website for medical students studying pediatrics. In spirit of IODE, I had 2 lovely ladies that were the key in making this initiative come together. And Lauren Kidney is the first one, who's now in Toronto at Sick Kids doing pediatrics. She was a leader of the pediatrics club in med school at the time, and so I approached her with the idea, and she thought it was really good as well. And the next one on the right is Mel Lewis, who is, at the time, was a leader responsible for undergraduate education for pediatrics. So she was responsible that all students come out of med school knowing the important components for child health. She had this unique vision where it didn't matter to her how students achieved their goals at the end, as long as they got there. Whether it was via lecture or questions, or reading a book, or doing a podcast, it didn't matter, as long as they get to this important point at the end of being competent. So essentially we sat down with Mel, and she gave us a list of pediatricians in the faculty, and Lauren and I just started cold calling and met with about 20 pediatricians, emailed them, sat down with them, and pitched the idea, and to try and get them, see if they'd come on board. Because we needed expertise to help make this go forward. And we were surprised that we had a lot of positive feedback. And the majority of the pediatricians thought it was great and really willing to get involved. And most people recognize this as a problem, but like everything in life, the diagnosis is usually easy, but the treatment requires lots of time, and people don't have time to commit to these things. But with this, the students would do all the legwork, all the hard labor of creating all the content, and the pediatricians would just have to check it over to make sure it's good and accurate. So they were really on board with this idea. Basically, we got funding. We were very lucky to get some support to have 2 students every summer to spend the whole summer focusing on this project, to really spend time to develop good material, to come up with different ideas. And for us, really, because as we progress through medical school, or I've put mine on pause, and everyone else has progressed through medical school, we wanted to always make sure that we're staying in tune with what's actually important, like what students actually want now, and not to assume that because that's what they wanted 4 years ago, they still want that now. So having medical students always make sure we keep the pulse. We always keep informed with what the current students want and what the changes that are happening. Because with technology now, the changes are so fast. In a year, it's unbelievable what goes on. And so this way we can really stay in tune. And now I'm just barely trying to keep up with our summer students because I don't understand what they're talking about. So it's about, that's what the students want. So we need to make that work and make that happen. So I always wanted to ask students and do research to see, do students actually like this? Is it actually improving their knowledge? Because if it's not, then we're wasting our time. Because we shouldn't just assume it's good because we thought it was a good idea. So we've really been doing lots of research, and we've presented our findings throughout North America and Europe, which has been really good to disseminate what we're doing and to get feedback on how we can improve. And one of the key projects that we've been doing is around how students learn in rural communities. So with the growing demand for doctors, medical schools are getting bigger. But there hasn't been a subsequent increase in number of hospitals or number of doctors that are teaching. So you have this challenge of how do you ensure that the bigger medical schools, that the students get good exposure to medicine, that learn the material on the wards. And my med school, when I started, it was 134 spots, and now it's 185. But there's no difference in number of teachers. There's no new hospital to train the students. So there's no increase in capacity to make sure they get good learning material. So what's happening now is that students are spending 9 months in rural communities as a more informal way to learn. So traditionally we would do third year, which is where we get our core learning, doing 6 weeks of pediatrics, 6 weeks of surgery, etc. Where now students are doing their 9 months in a rural community. So this is a photo of Peace River, which is 6 hours north of Edmonton by car, where they spend 9 months in a rural community working with rural family doctors, where they get hands-on experience over a period of 9 months, where they get to see, instead of doing pediatrics as a rotation, they see kids every day informally, and they have a surgeon come up once a week and get to spend time in the operating room. So it's a different way to learn in a much more hands-on approach. But then the challenge is that when I did peds in Edmonton, every week we have a half day of lectures by specialists. So these students don't get that in Peace River and other places. So how do you ensure that these students get access to the same high quality teaching and supervising and content that they would otherwise get in a big city? So we've looking into how we can, with Peace Cases, help fill this gap of ensuring the students get same consistent material no matter where they're studying, in rural communities or in the city. We felt that there is a strong role for it, and that students found it very, very useful as an important tool for them. And this goes from Peace River and also to Uganda, where I spent a summer doing an elective there. And again, Peace Cases came up several times. They have this hospital I was at has a nursing school attached to it. And again, there was a lot of desire for education in settings where it otherwise are brilliant individuals that just don't have the same capacity or access to resources that we would otherwise have here, largely because you have to pay for it. Our university is paying $10,000 per year for something that we've now made for free, and so every institution was doing that before. And so that's something that in other settings has been really key. And again, recently was in Israel on the West Bank and did a lecture, was asked to talk about it again, about there's a desire for, in this different settings where it's important. Education shouldn't be geographically defined. Everyone around the world, wherever you're seeing children, you should also know the same important material. It may be different diseases in different areas, but the important content is similar, and we can really fill this gap. And then, time, and in human resources, again, about the staffing, and we ideally would like to get someone to work on this full time, and we really think it would be important. But then about how do we align these with our competing interests? Ironically, it's been great that I've been able to go to Oxford and continue to be a student. Like I'm a professional student, my wife calls me, and it's true. But I've had more time to put into this than I would have otherwise if I was a resident. Lauren at Sick Kids just finished call last night, working 26 hours. She doesn't have the same time that we had before, and so it's just about how do we make these things work on our own time. But it's really about the team, and we've had a spectacular team that has worked on this project over the years, from the summer students, from residents and staff, and it's really something that with a shared vision and passion and interest, it's amazing what you can accomplish and what you can keep accomplishing. And I think we have a lot of opportunities going forward, but some uncertainties and some turbulence ahead, but we'll see what will happen, and we'll keep on doing what we're doing and doing the best that we can, and I think it'll still work out well. So that's all I want to talk to you, so thank you. That was interesting.
And to meet you in person and listen to what you are doing, it all comes to life, and it has so much meaning. You are an amazing person. We are so grateful. Our theme this year was making connections for the future of IODE. I like to think with the countries you have visited and the programs and the people that you encounter and the role model that you are making connections for Canadian health, for the health of Canadian children everywhere you go. Please bring it back to Canada. Thank you.